Good morning, everyone. I'm excited to be here. I'm sad to say that I haven't been back to UB since 2002. I've been to Buffalo in 2004 for a family event, but I haven't been back here in almost 17 years. And so I'm excited, not just because we're in a brand new building, which looks nothing like the old medical school that many of us studied in many moons ago. But it's an opportunity, it's a homecoming, it's an opportunity to share some of my experiences, but also to reconnect with people who help shape who I've become. I was born in Buffalo, but I was raised in Brooklyn. My parents left right after the blizzard of '77. I think they said, we can't take this anymore. But coming back to Buffalo was an experience. First, I actually want to thank everybody for having me this morning. I want to pay homage to my family who's up here in the front row, and Melvin's over there. I want to thank Dr. Walcott, one of my classmates from 2002, for having me, Dr. Kane, Dr. Berger, Dr. Prasar. There's so many, Dr. Severin, there's so many people that help shape who I've become, and I owe it all to you. Oh, there's Christine, Dr. Adams right over there in the Department of Emergency Medicine, and Dr. Menke with a very nice goatee right now. So I have a confession. I had no interest in coming to Buffalo. I'd come up to visit my grandparents on occasion. They were back and forth between New York City and Buffalo. But I liked playing in the snow, but had no interest in shoveling snow. I didn't really understand what lake effect really meant. And coming to a city when the sun came out at 4 p.m. and then went down at 5 p.m. for like 2/3 of the year just didn't seem like a smart decision. And I went to undergrad in Atlanta, and it was 80 degrees on a regular basis. A bad day in Atlanta was like 50, and people were like, "Oh man, we got to put on our winter coats." So coming up here wasn't really my expected plan. One of the things about my journey and about most people's journeys is you have to expect the unexpected. Those things in which we hold very near and dear to us are really there to keep us comfortable. But most of the challenges, most of the things that are very transformative for who we are or who we are to become take place by getting out of your comfort zone. So I came to Buffalo. And coming to Buffalo, I was trying to figure out, I was pretty insecure. It was a brand new environment. I went to a historically black college. I went to Morehouse College, which is a phenomenal school, but I had never gone to a majority institution before. I went to school with kids from all over the planet, but we had 2 white kids in my high school. And both of them grew up in pre-gentrified Brooklyn, and so we always thought that they were Latino until many years later when we found out their actual ethnicities. So coming here, coming to UB and going into Farber Hall, trying to figure out how this place right here was going to take this ragtag group of people and turn them. Some of you who spent time at Sisters Hospital may recognize some of the people here. That's Dr. Roger Walcott, who's a prominent vascular surgeon, and Dr. Mark Hennon, who's also Mark's cardiothoracic. Yeah, that's so funny, but no, not funny because they were all, all these people in this picture were highly brilliant, highly intelligent, very well-rounded, but to see what they've become is an amazing experience because we remember when we were just trying to figure it all out. But I was trying to figure out how this ragtag group of people was going to, move on and graduate from here. This is Dr. Charmaine Gregory, who's one of my good friends and also an emergency physician based in Michigan, and trying to figure out how we're going to come to look like this. And as you can see, Dr. Adams has not aged. Actually, none of these people have aged. Me and Dr. Kalori and Roger have become moving into the gray hair realm and some of the no hair realm. But these are a phenomenal group of people that I'm proud to say have been my classmates. And so after leaving Buffalo, well, actually even here before I even moved to Chicago, looking at Buffalo, I noticed there were major differences. I had never lived in a city before as an adult that had that super sharp demarcation between the haves and the have-nots, where ethnic disparities and ethnic differences were separated by a particular street. Bailey Avenue was that street that went right through the hood and separated, actually Main Street, I guess, separates the east side from the west side of Buffalo. But I had never realized, when you cross that side of the tracks, it's a completely different world. I had no idea when you going into North Buffalo that there was a completely different environment, that many blacks and many people of color weren't allowed to live there many moons ago. So coming here and looking at health disparities and looking at ethnic differences and understanding very subtle things between the Polish community, the other Eastern European members that were here in Buffalo, looking at the African American community, looking at the immigrant community that we were seeing on the west side of Buffalo, was really helpful to me because it helped me figure out what was the larger world going to be like. Most people from New York City and most people from Los Angeles and other parts of California, or even just the Northeast in general, assume that the rest of the world looks like those particular places, not realizing what happens when industries come and leave a community. Some of my family members work for Bethlehem Steel, and I didn't understand when a factory closed down how that could really depress an economy. And so I started looking at very subtle differences and looking at, how once thriving neighborhoods all of a sudden became destitute. Watching McDonald's close down in downtown Buffalo, it was like, wow, I've never seen a McDonald's shut down in my entire life. I've seen some that didn't look so great, but I've never seen a business shut down like that. And it was happening over and over and over again while I was in medical school. And so I started thinking about, not just why these things are happening, but what was my role and what could I do? Because I got used to the snow, I got really good at cleaning off cars in record time, starting from the top, using a broom, not using a little snow brush, pushing off that snow, and then having it fall to the side so you can get in your car in a much more economic fashion while at the same time cracking the door open so you don't lock your keys in there and making sure the engine runs. I got snow, cleaning off snow down to a science. And so it wasn't a problem to move to Chicago, where I wound up training in Cook County Hospital. I started off at the old Cook County, which has been referred to as the Old Lady on Harrison, and there were a number of different things that were happening there. Those same ethnic differences, those same healthcare disparities were emerging. And I think when you're a medical student, you see some of the stuff close up and personal, but when you're a physician and you have to have these very intricate and intimate conversations, you can't run away from it. And one of the things that happened when I was here in Buffalo and kept happening in Chicago, and I didn't know if it was just coincidental, is that people were like, wow, you're the first black physician I've ever met. You're the first black medical student I've ever met. And at the time, I had locks all the way down my back, and so I didn't look like your average medical student. One, there were only 3 black guys in my class, so all of us stood out in some shape, form, or fashion. But I realized that there was a level of power that came along with being in certain spaces and having opportunities to speak to people and be able to care for folks. My dad grew up on the west side of Chicago, and he was actually born at Cook County Hospital. And so just like moving to Buffalo, here I came in contact with family members that I had never met before. The same thing happened in Chicago, taking care of relatives, some in good shape, some in not so good shape, but having these conversations where people say, wow, because of what you said to me, because of our experiences, I'm actually going to take my medication. I'm going to come for my appointment. I'm going to come for my follow-up. I want to follow up with you. Can you be my regular doc? And I was like, whoa, I'm emergency medicine. I don't do this stuff on a regular basis. I only want you to come in and say hi if I'm seeing you on your way to the appointment, but I don't do clinics. I don't do well. I have a short attention span. And so I don't many of us, especially the people in that fourth row, can understand that. We do see many people coming in as I don't want to say repeat offenders, but coming back because they don't always have access. But my goal is not to take care of people in that capacity in a clinic setting. There are other people who are dedicated their lives to doing that. But Cook County was a very interesting place. I had a phenomenal experience in the Department of Emergency Medicine and just as a phenomenal experience in the Department of Trauma. And the TV show ER was based off of Cook County Hospital. They called it County General. Now, summertime in Chicago is a very interesting place. Summertime is beautiful. People are out on Lake Michigan. They're riding their bikes. They're running. But summertime is also the time where you have the highest concentration of penetrating trauma. But this day was different. This was August of 2005, and it was cold and rainy. It was like 55 degrees in August, which is crazy because usually in Chicago it gets like maybe 95, 100, 105, even 110 if you go a little bit further inland. So you have one extreme to the next, minus 20 in the winter, 105, 110 degrees in the summertime, which is not making for much of a comfortable situation. But this day was very different, and there was nothing going on in the emergency department. And one of my coworkers looked around and said, "I'm bored." And all emergency physicians know you're never supposed to say that. That's like a curse word. Don't even use the Q word or saying that it's quiet. But he said, I'm bored. And we were on a 24-hour trauma call. This is also, did work hour restrictions? Yeah, work hour restrictions had just kicked in. And so we weren't allowed to do 36-hour calls anymore, which some of us who trained outside of New York State, we didn't have access to the Bell Commission. And so we wound up working very long hours. And when he said it was quiet, it was because we'd only have blunt trauma coming in. Blunt trauma means that you have somebody coming in who might have been in a motor vehicle collision, not penetrating, not a gunshot wound, not a stab wound. And because he said he was bored, he next followed, I hope something exciting comes in. And, because excitement means procedures. Excitement means that there's penetrating trauma. You get a chance to intubate. You put in a chest tube. But excitement also meant that you had another young Black or Latino male or woman who were coming in as a victim or survivor of trauma. And looking around the room, the only two people of color in that entire room were me and one of the clerks. And at the time, I was about 27, maybe 28. And I lived on the south side of Chicago, which is where a lot of the traumas took place. My family lived on the west side of Chicago, which is also where a lot of those penetrating traumas took place. My cousins in Chicago, some of them weren't doing so well and were involved in some street activity. So I always wondered, is one of them going to come in? If I was in the wrong place at the wrong time, am I going to come in? Am I going to be this patient? And are my same classmates who were like, yeah, I hope something exciting comes in, if they see me on a stretcher, am I going to be another science experiment? And I started thinking to myself, I said, yeah, it's important for us to be able to learn these different surgical skill sets that could be life-saving and life-altering, but what if we created systems that prevented people from becoming patients? And so I started looking at violence, and I started thinking about violent conflict through this public health lens, looking at identifiable risk factors that could be transformative and really help improve the vitality of the community in which we serve in. So I wound up moving back home. I moved back to Brooklyn, New York, and I'm practicing at Kings County Hospital, which is directly across the street from my elementary school. I've actually been a patient in this school. I got stitches once because a fire extinguisher fell on my head. I was pretty upset because we took an ambulance, but they didn't turn on the sirens. And I was kind of like, man, we could have just walked across the street. But that's a whole nother story. But moving back to Brooklyn, I moved back in 2006, and this was a little bit interesting because now I got some credentials next to my name. I'm not just a resident in training, I'm an actual physician. And I'm working in the same neighborhood that I grew up in. I'm seeing some of my classmates, some in good shape, some in not so good shape. And I remember a couple of months in, it was a Labor Day weekend. And Labor Day in New York City is really, it's a great weekend, but it's really traumatic because it's the Caribbean Day Parade, which often has a lot of violence. Not because, one group of people is more violent than others, but there's a lot of drinking. Same thing like when you have a Sabres game, how ECMC winds up double staffing and triple staffing the ER to make sure that you have enough coverage. The same thing kind of happens on Labor Day. And I wound up sewing up one of my classmates who got assaulted and was handcuffed to a stretcher. And I'm like, man, I was like, this is getting real. But then similar things kept happening over and over again. Treating patients, treating some of my colleagues who weren't in such good shape and trying to figure out why. So a couple of things happened. I had started sketching out a number of different ideas on what was to come up and create this violence intervention program, looking at violence, looking at conflict, but it was the same thing that happened over and over again. I present to the higher-ups at our hospital, and they were like, yeah, Rob, wow, that's a great idea. Sorry, we don't have any money. Great idea. Wow, this is interesting stuff. You should do a talk on it. Yeah, sorry, we don't have any money. And I kept hearing about this stuff over and over and over again. And I was talking with some of my classmates and talking to people this morning. I never wanted to do violence intervention work. My job was to do global health. I was going to create programs in other countries. I got a chance to study abroad at UB, and I spent a few months in Kenya. I worked in Peru. I worked in Guyana, South America, Brazil, all over the world. And that was what I was supposed to be doing, not focusing on violence prevention. And because I was getting the runaround and I didn't know how to get money to do programming, I kind of went back to my initial love, which was global health. And so I had an opportunity to go to Haiti after consulting in 2008 about a clinic that was being built, and had a series of emails that went back and forth about equipment that was needed and not buying equipment in the States and buying it at least in the Dominican Republic. So if it breaks down, that equipment could be serviced so it doesn't wind up in someone's ditch. And the woman who is the executive director of the nonprofit and helping head the clinic initiative said, now that you're a consultant, when are you going to come down to Haiti? So I'm like, wow, I'd read about Haiti as a kid. I knew all about Toussaint Louverture. I had a comic book at home about Haiti and Toussaint Louverture's, role in the Haitian independence. My mom was a teacher. My grandmother was a historian. My dad's an activist. And so this is dinner table kind of conversation about Black history and leadership development and community engagement. So my upbringing wasn't completely typical. And I had an opportunity to go down to Haiti, and myself and one of my co-residents, whose family happened to be from that region, started doing a needs assessment. We're figuring, all right, we have this clinic, and you have people coming from this entire corridor, but nobody knows what anyone else is doing. So we figured, let's start having conversations. This is me with one of the Haitian healthcare practitioners. We're just taking notes, figuring out what was going on, what needed to happen, who the key players were, how do you get somebody to and from one of these clinics at minimal cost. And so we were working in rural Haiti in a place called Terrier Rouge, which was, I've been in a rural communities. It looks very similar to what we see in Kenya and what I saw in Guyana, but this is a little bit different because Haiti was only 4 hours away. Port-au-Prince is only a 4.5 hour flight from New York City. Haiti it's quicker to get to Haiti than it is to get to Los Angeles from New York City. And in Brooklyn, particularly the central Brooklyn area, we have the largest Caribbean community anywhere in the world outside of the Caribbean, with a large Haitian population that we were servicing. So this is kind of hit home. And this is all before the earthquake. So we're doing needs assessments and learning how to link one facility to the next, to the next, to the next, to kind of create this almost like a Kaleida health system in northeastern Haiti. But then things changed. January 2010, this building, which was the Capitol in Port-au-Prince, changed up and was devastated. The earthquake hit January 10th of 2010. And so when we were looking at building more of a complex system, everybody switched into disaster mode and was focusing on working and treating people in some of the tent hospitals that were in and around Port-au-Prince. This is me working with International Medical Corps and Medics in one of the tent hospitals. And it was important. We were providing care. I was down there about 2 to 3 weeks after the earthquake. I knew minimal Creole, but we brought an entire team down there with us. And I thought we did some good work. But there were some things that we noticed. One, the Haitian physicians that were working within the community that still, their skill sets were still amazing given their circumstances. They wanted to work, but people weren't paying attention to the local personnel because everybody was focusing on, let's go save the day and work with this population. We also noticed that everyone was bringing in their supplies from outside of Haiti or the Dominican Republic, and which meant people weren't buying anything on the island, which meant money wasn't going into circulating on the island, meaning there was no growth and development from an economic point of view. Physicians were being imported, money and medical supplies were being imported, and no one was paying attention to local personnel, which means if you're a professional, you can't make a living. You can't make a living, you've got to leave the country. And so you wind up having this complex thing we refer to as brain drain, not because people don't want to stay within their own countries and serve their own people, but because they don't have the opportunities to do so. And so we started switching it up. Instead of just focusing on disaster management and more of a medical tourism, we started meeting with local Haitian professionals in the community and continuing on with these needs assessments that we had started before the earthquake and looking at what was needed for their communities. And we realized, what if we just focused on training and development? What if we built capacity? What if we could become obsolete as physicians and really work ourselves out of a job? There's so many different NGOs that wind up staying in places, and I think they do good work, but nobody learns how to pass on leadership. And we were talking about that in the breakfast this morning. No one figures out, we don't often do that. We want to train local people to be able to do this stuff. People like having visitors come in and say hi and learning about their cultures, but no one wants to become dependent on an outside community for the sole purpose of their survival. And so we started training drivers and laborers in first aid and emergency response, which was laying down the preliminary foundation of an EMS system. Any of you who've spent time in New York City may know about dollar vans, which are vans that run up and down the major boulevards. They run a lot faster than our public transportation, but they're a little bit cheaper. And MTA doesn't like that because they don't get a cut from that. But the same kind of cabs are in existence in Haiti, and they're called tap-taps. And so we were training tap-tap drivers and laborers in how to do emergency response. But we took it up another notch because we were teaching them, we were doing an instructor's course so that we didn't have to go back. They were also teaching us all about tropical medicine and practicing in resource-limited settings. And so it wasn't this paternalistic US type of thing where we're coming in, we're saving the day. It went back and forth. And so you had a true cultural diffusion. We're just doing splinting with some simple materials that you could find in rural communities. This is stuff that we learned in Boy Scouts, but people are actually using these skills to get people to and from accident scenes and can mean the difference between loss of life or limb. But I moved back to Brooklyn. I'm back in Brooklyn. I'm thinking about this stuff. I've probably been to Haiti about 14 times, back and forth, doing training over the past X number of years. And I'm back in Brooklyn, and I'm still lecturing about violence intervention, and I felt bad because I wasn't doing anything about it. I was just lecturing and talking about it from this, not a theoretical framework, as a practitioner, as a member of the community who's impacted by this stuff directly, but it was bothering me because I kept seeing images like this, which is a gentleman with this is a GSW to the back, the other one was a stab wound to the back. Seeing images like this, which is what we call a $1.50 scar, where somebody takes a razor blade and cuts you from the angle of your mandible all the way down to your chin. And we call it a $1.50 scar because they say it takes about 150 sutures to sew that back together. So you're seeing images like this over and over again, and you're like, well, why does this stuff keep happening? And particularly back home, in my neighborhood with people that I actually know. And so in 2009, I launched a program called MMSEM. One, because I wanted to make sure that we improved the numbers of minority students, particularly underrepresented minorities in the field of emergency medicine. How do you take care of people in a community and have no members of the community that are part of that solution process? And so I launched MMSEM with the help of some of my colleagues for the sole purpose of introducing emergency medicine, but focusing on project and program development. It's like 6 weeks of emergency medicine boot camp. It's not easy. So Sean, if you come hang out with us, you're gonna get to know that stuff very intimately. But MMSEM, and we're actually in our 11th year of running MMSEM, and this is our first group of students. 1, 2, 3 or 4 of these people in here are now emergency medicine attendings around the United States, back from that initial group. And they were tasked with helping. I'd never had a true team before doing violence prevention, where we had this stuff for global health, but not for violence prevention. And they were tasked with coming up with and helping me develop a violence prevention program that was looking at best practices approach, that was drawing from their own personal experiences, and they came up with the name CAVI. Which stood for the Kings Against Violence Initiative, but we're moving away from that because we do much more than just preventing violence. CAVI is a hospital, school, and community-based violence intervention program focusing on rethinking and reframing this conversation around violence and trauma. Violence is not just somebody shooting someone or stabbing someone. Trauma and violence is vicarious. It can be passed down from generation to generation. It's environmental. It's cultural to a certain extent, because I say cultural not in the terms of an ethnic sense, but because if you're taught that in order to deal with conflict, you have to solve this stuff violently because of the code of the streets tells you to do that, and if you don't change this dynamic with aggressiveness, it's viewed as tolerating victimization, which sets you up for a bunch of opportunities to be taken advantage of. So when I talk about cultural context, this is what I'm speaking about. And so they came up with the name CAVI. And that was in 2009. I was like, great, yeah, we have a team. So we applied for grants. And they were like, again, great idea, no money. And I went out, started talking to people and started talking to other academicians. And they were like, sorry, you need to publish some stuff, and great idea, but sorry, we don't have any money. And I talked to my dad. I think I'd just come back from Haiti in summer 2011. And I was venting to him. I was like, man, we applied to this grant. We didn't get it. Nobody wants to invest in us. And he looked at me, and in only the way that someone 60 plus with no filter can talk to you. And he said, why the hell should they give you any money? You haven't done anything. And I was like, wow, that's kind of harsh. He said, all you done is just talk about the problem. I was like, man, you're right, but I didn't really want to hear it like that. And then, I started talking to friends of mine, who were in business. I remember I started reading Incorporated magazine. I started talking to friends of mine who were social entrepreneurs. And I learned a couple of concepts. One was something called sweat equity. So for people who are familiar with the business community, sweat equity is basically you have skin in the game. Why should someone invest in your endeavor, your business, your project, if you have nothing to lose? You have nothing to lose. That investment winds up, if that investment goes sour, you're not going to pay anything back. You're going to run the first sign of trouble. So you need to have a level of, there's the feedback. You need to have a level of sweat equity. The next thing that I learned is that nobody invests in anything that's theoretical. The economy isn't what it used to be, and people want to see something. It doesn't have to be perfect. And I'm figuring, we've been spending all this time in Haiti doing this stuff on minimal shoestring budgets, and I'm like, man. I was like, how do we launch this? And my problem was that I was looking at solving a problem from an academic framework, not solving a problem based on the best way that I knew how. We engaged members of the community in Haiti. I was like, why don't we engage members of the community in Brooklyn? You got friends who said, I'll help you out. And even though our project didn't look like what we wanted it to look like, we had to start somewhere. And so we launched. We launched Kavi with no money. I spent money out of pocket, my own pocket, for about 2.5 years. And we started off in the schools. So when we were first creating Kavi, the goal was to create this hospital-based intervention program just to focus on decreasing recidivism, making sure that patients didn't come back to the hospital after they were injured, because 40 to 50% are going to come back with repeat injuries, 20% are going to be killed. That was our primary focus. But there's a big high school campus across the street from our hospital, and major issues with conflict, and you had 3 or 4 schools within that high school. So you got different sources of income variability, different sources of economic access in one particular campus, which creates a greater divide, the haves and the have-nots. There was one school with air conditioners and one school without air conditioners. One school that you had to take a test in order to get into. The other school was a feeder school for kids coming from juvenile detention centers. Another school had primarily students who were new immigrants coming into the country. And so you have a lot of stuff going on, which means you're going to have a lot of conflict because not every, trying to figure out how do you bring these people together. And so we started doing school-based interventions, focusing on small group workshops, dealing with mediation, conflict resolution, skill development, idea development, and then evolving into restorative justice practices. Was the first thing that we did. And after 2 or 3 months, we realized we were onto something. The goal wasn't to create a school-based program, but after a couple of kids said, Dr. Gore, you coming back next week? And I was like, yeah, I think we're onto something. So we continued to evolve our school-based program. But because you start one thing, then when other people start hearing about what you're doing, they go, oh, how can I help? I want to help you guys out. And so a couple months later, we launched our hospital-based intervention, focusing on decreasing recidivism. This is a newer picture with our intervention specialist, Jessica Maldonado, who I've actually known for over 30 years. She's the sister of my foster brother. And this is one of our patients, paraplegic. He's a really dynamic spirit. He was shot multiple times in the back, and here he is as a part of his rehab. But our hospital-based intervention works with people who've been injured as a result of violence, making sure that we provide advocacy work, but also helping link them up to psychosocial support systems, making sure that if they are dealing with depression and anxiety disorder and are self-medicating, they have access. It might be on a most basic level, just helping get them an identification card, making sure that we ensure that there's a level of safety so when they leave out of the hospital, they go back to a safe environment. Because if they don't go back to a safe environment, and they have no way of they're not going to come back to the hospital for their follow-up appointments. They're not going to, as a trauma surgeon and stuff, you might say, man, I had this patient, he won't come up for follow-up. As an orthopedic surgeon, you say, man, I had this guy, he had a GSW to the tib fib, and he won't come back and get his cast off and come back for wound checks. He's just not interested. But nobody took into consideration that he lives in a hostile territory. And now that he's walking with a limp and with crutches, he's an easy target. And even though he's on the same street line, the same bus up Nostrand Avenue, he's got to go through certain areas, and he can't run if somebody starts chasing him. And so he'd just rather not go. It makes sense to me, but nobody bothers to have these conversations. So our team members work alongside with hospital social workers to ensure that. In the school program, I actually want to go back a little bit. Most of the kids, we have over 200, 250 kids in school and in after-school programming. And these are students who've all dealt with some sort of trauma. If you live in central Brooklyn, you deal with trauma. If you live in New York City as a whole, you deal with trauma just because of what we see and just the different social dynamics that take place. But some of our kids are gang members. Some of them have gang affiliations. I had gang affiliations when I was a kid because you live in pre-gentrified Brooklyn. You've got to get to and from school. I carried razor blades and screwdrivers from the age of 11 up to 18. And I graduated valedictorian. I wasn't a bad student, but I wanted to make sure that I was safe. And first time you get jumped, getting jumped in New York, it's like a rites of passage. But the first time it happens to you when you're like 10 or 11 years old, you go, I'm not going to let this happen to me ever again. And so this is some of the stuff that some of our young men are dealing with. But we're also working with young women who also are dealing with their own traumas. Some of them are high-performing students, but when you go and find out more intimate details about their home life, things are very different. And so we try to create a safe space. That's the first and foremost. We want to create a safe space so that they can actually talk to us about these issues. Make sure they'll disclose to us information that might be sensitive, but also because we're not their teachers, we're not grading them. And so we can serve in a greater role as an advocate. In addition to that, I'm an educator, and I always think about capacity building. My goal is not to do this in violence prevention forever. The goal is to train other people to do this stuff. And one of the things that our organization does is help train other violence intervention programs around New York City in trauma-informed care and violence prevention, particularly our unique experiences as emergency physicians. But there are a couple of things. How does this stuff apply to you? And this morning we asked the question of the medical students and the faculty, I don't care what you want to do when you grow up, what problems do you want to solve? What are you going to do? And if you have an idea, how do you implement it? One of the beautiful things about medical school is that we learn how to digest large amounts of information in a very short period of time. It's going to take you so far, and your classmates and significant others are going to be pissed off at you because you can recall things with a very intricate detail that piss them off. But it happens all the time. My wife, she just rolls her eyes, and I'm like, I Googled it, I told you. But one of the problems is that we're afraid to make mistakes. And because we're afraid to make mistakes, we're taught to become perfectionists in everything we do. And that's not a problem, but we suffer from the point of analysis paralysis, and things don't get done. And so projects and ideas and programming and even things like, how do you, coming up with an idea and how do you prototype it, these are things that we don't experience. And so speaking with some medical students of mine who was an engineer and an inventor before, he was like, I was trying to create this process. I was like, we got to come up with all these things so that people understood these ideas and they can implement stuff. And he's like, about engineering design process? And I was like, nah. And he's like, yo, go Google it. So I Googled it on a shift. It wasn't too chaotic. And I was like, oh man, I've been trying to create this whole process all along, and it had been in existence, and all my engineering buddies were like, oh yeah, we've been through this. But with engineering design process thinking, you have to think, what is the problem I'm dealing with, okay? Then after that, you're gonna come up with a series of ideas, and we all brainstorm ideas, but many of us never move beyond the brainstorming part of the process. And so ideas die in our notebooks, or they wind up evaporating out into the ether. And so with design process thinking, figuring out what's the problem I'm dealing with? How do we come up with potential solutions? Let's figure out how to centralize a number of those different solutions and come up with a prototype. You come up with that prototype, you implement it. And then after that, you figure out, how do we do this again? Better, stronger, faster, more efficient. And so you never stop this thought process of evolving ideas. It's something that you continue to do over and over and over again, which is why we have 10 versions of the iPhone, which is why we always wind up getting these updates, which I got to update when I go home, which is why we always have these different updates to ensure that we continue to improve this process. We're dealing with people's lives. And thinking about tackling problems only from this purely theoretical framework, only focusing on talking about ideas just for the sake of debate is completely useless. And we have a role and a responsibility as physicians, as healthcare providers, as people in the community to continue to rework our thought process and continue to come up with ideas that can be really transformative for the people we care for. When I take care of cases in our trauma area at Kings County Hospital, those are my neighbors. Those are my neighbors. Those are some friends, they're family members. This is not just a science experiment. And so thinking, how do we become more effective and more efficient, and really learning how to adapt to the challenges that we face is essential for the survival for the communities in which we serve. For more information about some of the work that we do, this is our email, info@cavibrooklyn.org. You can check us out at cavibrooklyn.org. But I want to thank you for welcoming me back to Buffalo. It's been a pleasure, and at this point, I think we can entertain questions that the audience might have. Thank you. Actually, is the mic? Okay, so then any questions, we have a mic. Med students that actually know whose names, I'm gonna start passing it on to you guys. That's crazy. This is the new UB. Oh, I asked, do you have any questions? If not, all right. Well, I guess thank you. I guess we can wrap up.
No.
Oh, that's sorry.
What effect have you had in the Brooklyn area?
We have, I just think about like our hospital-based program. The first thing is that we started educating a lot of our physicians about trauma-informed care, which is basically a biopsychosocial model of healthcare, incorporating both mental health practices as well as the physical practice of medicine. Many of our trauma surgeons, our emergency physicians don't think about recidivism. You know, it's like, all right, we patched them up, you know, they're alive, and let's get them out. If they come back, it's not my concern. And that conversation started changing once we started thinking about risk factors with why people are perpetrators of violent events, particularly when we started seeing mass casualty shootings taking place in communities that were a little bit more affluent. Then we started getting a different kind of attention. But also, you know, it's a way to save money, because nobody wants to treat patients over and over and over again and expecting them to have an improved outcome. And so the first part we wind up doing is just educating our coworkers about violence prevention. If you look at, you know, for the hospital program itself, we are now having people who are re-entering the workforce because they have a different level of psychosocial support. Dr. Pizarro and I were talking a little bit earlier about the role of mental health practices, and many people coming from marginalized spaces, coming from the east side of Buffalo, whether you're African American or white American, if you're coming from a dysfunctional family, or just coming from a place where mental health practices were only given to people unless they were crazy or institutionalized. You know, I don't call people crazy. My wife might call me crazy sometimes, but people don't always have access to that stuff, and there's a stigma around mental health. And so introducing, telling someone, look, we're going to help make sure we check in with you and make sure you have a level of support. Do you want support? And they go, yeah. It's like, okay, well, there's certain things that I can do, and there's certain things that some professionals can do. Because I know the professionals, would you mind me taking you to that place so that you can get some additional help, so people can check in with you? Because I know every time you leave the house, you got to smoke a blunt because you're having bad anxiety, or you wind up drinking alcohol because marijuana shows up in your tox screen, and because of the homeless shelter you live in, because you're on parole, you can't self-medicate with marijuana, which might be a little bit better for you. So you wind up drinking alcohol to self-medicate. Because you always have these issues with alcohol and violence and getting combative, and you wind up going into jail because you violate your parole, because you punched somebody in the face because you were scared. Making sure that you have a safe space so you can talk to somebody and decrease your level of anxiety has been really helpful. We have students now who've been our program participants. We have one guy who's in med school right now. He's at Brown University. We have another student who's applying he wound up, this is one of our hardcore knuckleheads. I call them my knuckleheads because, that's what they are. They're brilliant people, but like most teenage guys and girls, they're a little bit special. For parents, you kind of understand what that means. And one guy's actually applying to West Point. He had to join. He joined the military right out of when he graduated high school. Actually joined the reserves, and his commanding officers are recommending him to apply for West Point right now. We have other students who are pre-medical students. We have people who are pre-law. We have one student in a master's program now. We've been doing this work with CAVI with actual programming since 2011, and the next phase in terms of scaling up is looking at digital platforms so that we can train larger groups of people. Yes, Dr. Kane.
Hold it, yeah.
So, in the last few weeks, both Stony Brook, Upstate, and Buffalo have had their LCME accreditations, and I know Downstate is coming up next year, I think, from talking with the deans. So the whole LCME visit, we exist because we have a medical curriculum, and we're accredited as a school. So have you been successful in getting reception and being able to implement in the four-year curriculum these very principles that you're managing and trying to deal with?
Yes, we just launched a platform. It's still in the beta testing, but utilizing medical students as a part of a social medicine course where they get a chance to spend time in the community. We already have this up and running with resident physicians from the Department of Emergency Medicine and the Department of Pediatrics who participate in, I'm having a brain fart for the actual name, but it's like a health advocacy workshop where they spend full 4 weeks worth of time working with different elements of the program. We have the same thing happening with the students from the School of Public Health. In order to graduate from Downstate Public Health, you have to have at least 200 hours of field work. And again, learning something from a theoretical framework is very different in terms of practical application. And so our workshop facilitators are coming from those different spaces and places. Our tutors, our academic enrichment program was actually started by downstate medical students as a way to help provide additional resources for some of our lower performing students in our in-school and after-school programming. Hopefully by this fall, we'll have the full-fledged 4-week workshop that's going to be implemented over the course of 4 years for the medical school. And we're working with the Office of Diversity and Inclusion with Dr. Carla Booten Foster. Yes, Dr.
Hi, I just wondered whether you could imagine a medical school sponsoring a CAVI kind of program with medical students and residents and faculty leading it, or would it be perceived of as, medical imperialism?
No, I think that's a great question. That's exactly what we have. One of the beauties of being a part of a medical school is you have different kinds of resources, and that took me a while to understand. We understand financial resources, but we don't understand the power of human capital. And utilizing our medical students help co-facilitate workshops. Our resident physicians help co-facilitate workshops. Our Master of Public Health students help us do data tracking and tracking research. So we were able to do a whole lot with no money. That's the only reason why we were able to survive and continue to exist through the help and support of SUNY Downstate School of Medicine. And it continues to evolve because I think once you see one student getting involved in a project of this nature, and you start seeing, oh wow, is there a possibility of me being able to implement another element of this type of program to enhance the quality? And we're pretty welcoming to that. It's not like, okay, no, this is only one thing that we're doing. We're very receptive to ideas. The actual name CAVI came because we had, matter of fact, one of the former post-bac students from UB who went to Downstate for medical school came up with the name. And so Buffalo is actually a very integrated part in what we're doing, but you have to have students and academicians as a part of the decision-making process. If it's only something that other people wind up doing, then you're not going to wind up having success. A big part of that is finding out who are the other people in the community who are also doing that work. And that way you have credible messengers and finding that bridge to what's going on here at the medical school and the campus with the outside community, other than looking at like this ivory tower, which we don't have access to, or even looking at just the hospital system itself. These are things that people wind up gravitating to, not just because they have a personal health problem. Gentleman in the back in green.
Are there efforts to bring this outside of Brooklyn?
Yes, the plan is to bring stuff outside of Brooklyn. Running programs, even multiple programs within Brooklyn, is pretty tough because we don't have an endowment that we'd like. We're still pretty much on a shoestring budget. It's getting better, but a lot of our money is government money, which takes anywhere from 6 months to a year and a half for us to access, which is kind of problematic, and one of the reasons why we're looking at more comprehensive fundraising and looking at other platforms that we can utilize as a revenue-generating stream for the work that we're doing. By the way, this is none of this stuff I learned in medical school. This is all trial and error, so we have to definitely experiment. But as far as moving beyond, one of the things that we'd like to do is train other people to do that. For me, I have working knowledge of what goes on in the Buffalo community, and I still have friends and family that live here. So there's a connection, but for places that I'm not familiar with, it doesn't make sense for me to go there and say, I know what's best for you. I think it's a lot more effective for us to figure out, who are we dealing with, what does the community need, and how do you empower other community groups to be able to do that work a lot more effectively, who have an even greater intimate knowledge of what the community needs are. Yeah, yes.
You talk about revision being a big part of your work. Can you talk a little bit more?
I can't hear you, I'm sorry.
Sorry, you talk about how revision and tweaking things is a big part of your work. Can you talk a little bit about the first workshops you had in schools, and possibly about like a workshop you thought would go really well but actually didn't hit how you wanted to?
In Brooklyn, and particularly in hip hop, the art of the freestyle is very important. And you go into a situation, and same thing, we do this every day in the emergency department. You have a set of circumstances, and your patient's dynamic, circumstances, substance abuse, just a full moon, a Friday night can completely alter what your plans are. I remember one workshop that we were doing, we were supposed to talk about leadership and development, but it happened that there was a teacher's classroom that was set afire and torched down the hall from where we work. Not while we were teaching, but like a few hours before. And then there's another student who was in the school. Her brother was stabbed with scissors in the head multiple times and was a patient at our hospital. He was stabbed by a kid who had mental health illnesses, and they got into a dispute over a basketball game. And so you wind up having to change. You have this lesson plan, and in front of you, and what you plan on talking about. You memorize all these series of questions, and you realize that's not what they need. And so in emergency medicine, and I like to use a lot analogies from emergency medicine. You're constantly evaluating and assessing and reassessing the situation at hand. Actually, in healthcare in general, you look at one patient, 5 minutes from now, you're in the ICU, and then 30 seconds later, the patient's vital signs are completely shifted. And so when you're running workshops, you have to kind of figure out what is the language of the people there. Are the kids paying attention? Are they not paying attention? Are they distracted? Are they on their phones? Are they just distracted because they've got a number of other things going on? What does their body language tell you? Does that kid look like they've slept? Do they look disheveled? Do they look like they're just focusing on eating all the food that you have there, because not just because they're hungry teenagers, but because they haven't eaten since yesterday? And so having an ability, you have to kind of find out, hone in on one individual, but then also look and see what the overall culture of that room is for that point in time. And one of the reasons why I like to advocate having a team is because you can't just do that by yourself. So when you have a kid, we wound up having to change up those series of workshops, and we also could tell that some other kids were really distressed about some things going on because they knew the kid who was stabbed. We had to take some folks out of the classroom. So one other person kind of continued the overall group discussion, and then we wound up doing individualized sessions with some of the kids that were participating in that workshop, which was something that we started doing even more regularly, just checking in. You have your general group workshop that's taking place, and we do our workshops 3 days a week during the school and after school. making sure that you find out what the individual needs are, but also what are the collective needs of that entire group. And then you wind up tweaking it and asking, did that work? Did that not work? Are you okay? Just basically checking in. If you check in with somebody, they're going to tell you exactly what you need, what they need. But most of us don't. We want to assume that because we become very insecure and at figuring out what other people needs, because especially as physicians, because that means that we might be wrong, and we don't want to be wrong because there's a lot of shame that comes along with being wrong, and we've got to figure out how do you move past that. Yes, young lady.
How did you spark an interest in your students to participate in the workshops when you first began, or did you just have them handpick them, I guess?
No, excellent question. When we first started working with students in Kavi, they called us the program. They were like, man, I got to go to the program. We were working with the kids who the teachers and the school administration were having problems with. Who was on their second and third high school? Who was getting into fights on a regular basis? Who was throwing up flags? And they were concerned about some major stuff popping off in the school. And first we started taking kids out of class. And who doesn't want to get out of class? So you got to figure out where are they? So we took kids, we'd be like, you want to miss class? You want to come with us? They'd be like, fine. They were in there, but they weren't being functional. Then the next thing, we brought food. And our food was much better than the free. So for people who aren't familiar, free is free lunch. And pizza day, chicken day, might not be bad, but those other days it's a little bit suspect. And so we made sure that the quality of our food was much better than what they were serving in the school. So those were two incentives to bring them there. One, they got out of class, and number two, they at least got to eat. And since they were going to be there all that time, and we're doing this on a regular basis, they started anticipating that, I can get something out of it. I don't have to go to class, and I get some better food than what I was going to get. All right, I'm going to start listening to you. But it wasn't easy at first. We kind of had to figure out what they needed. We had to go to the classroom and pick them, go get them, because they didn't want to be in a group where it was only all the problem kids. They were like, one a guy named Jordan, he said, man, that's where everybody goes when they get kicked out. And it's like, maybe we need to alter our practice and not just having students that the school deans were sending us, but let's start seeing, do you have a friend that you'd like to come in? Because if you bring your friend in, then you got a different kind of support system. And then it's not like, okay, it's just us versus them. We also started bringing in some students that were actually higher performing and not getting in trouble. But when we start looking at what was going on outside the school, it's like, oh, okay, this is somebody I respect, but they deal with some of the stuff just like me. And so we have a different kind of bond. And this is a series of just, asking questions and reassessing, going up to the school multiple times throughout the week, checking on students in their classes, going to their homes to find out what's going on and making sure that they're coming, how come they're not coming to school. It's the same kind of stuff that, your primary care physician, we'd like them to do. Or any sort of caring person would like to do, just making sure we check out what the best interest of that person is, but we don't always do that. So we kept retweaking it, reworking it, and then eventually we started building up a group. First, you just have to have that group that's there. If there's nobody there, nobody wants to come. It's kind of like nobody wants to be the first person at a party. And unless you make some sort of incentive, if you got free drinks before whatever, then everybody goes. Same thing with med school lectures. If you got free pizza, then medical students come to the lecture. You don't have any food, you don't have any hot wings, no buffalo wings, nothing. Med students aren't going to come to the lecture at lunchtime. They're like, why should I give up an hour of my lunch period to come sit and listen to somebody talk about some crap that I don't care about? So you got to incentivize it. And so you're always retweaking and reworking these incentives as well. Yeah, sure.
Hey, Dr. Gore, thank you for the presentation. I guess to piggyback off of the previous question and the question that Dr. Passar asked, how did Kavi actually choose what high schools they would go to influence these students? I know there's many high schools in Brooklyn. So what made you choose those specific high schools?
It was across the street from the hospital. So we're at two different high school campuses. One is Wingate High School campus, and the other one is Eagle Academy. And there are multiple Eagle Academies throughout New York City. And Eagle Academy is an all-boys school. And Wingate High School campus is right behind, when I exit the back door of the hospital, it's right there. And we figured, okay, I'm right here. I don't have a whole lot of time to travel throughout the city, so let me just focus on what's in my backyard. And so we were already having a number of patients that were coming through, so we started working at that campus with a particular point of contact in one of the schools, and then we moved into multiple schools in that building. Eagle Academy is in the Ocean Hill, Brownsville section of Brooklyn, happened to be an 8-minute walk from my house, so it makes a little bit more sense to do it there. Plus, we had some kids who were involved in gang activity that one of our mental health specialists was following up with, and they happened to go to that school. And you always want to meet people where they are. We decided not to do things after school at first because kids weren't going to come. This is not an after-school program crowd. But if you pull them out of class and you're already in the building, cool. You've met them. But one of the kids that we were following up with didn't, he wasn't going home, but he was going to school. And so he was sleeping at friends' houses and other relatives, but we figured at least the school was a central place that we could wind up having our mental health specialist meet with him. And then after a couple of months of being there, the school asked us if we'd be able to do a program there. And we've been doing it ever since. Oh.
Thank you, first of all, for a wonderful talk on a very important subject. I want to ask you, you had mentioned when you were in Haiti, you were helping the community by training the cab drivers. And you mentioned also that you had something that's very critical is the access to coming back safely for return visits. Are you doing any collaborating with the cab drivers in Brooklyn for the safe transportation of patients to come back? That's one part of my question. The other is a lot of communities now are seeing an increase in violence by police officers who are supposed to be protecting our safety. And I had the privilege in the Tidewater area of working with the police alongside my medical colleagues in going into schools similar to what you're describing about, 15, 20 years ago. And we found it very rewarding because the relationships that kids started to build with the police officers that patrolled their community, I think were instrumental in helping reduce the lack of understanding or the lack of perceived empathy towards the plight of the people in the community. So I wonder if you're collaborating with the police in the Brooklyn community, because it seems we're coming to a really critical junction in our society with, combat really essentially between the people who are supposed to protect our safety and the community members who are paying for it. So thank you very much for a really good talk, and I'll shut up now.
Oh, no. No, thank you. You've actually just given me a good idea in terms of, looking at some of the cab companies to ensure safety. I think this is something maybe Uber or Lyft would love to support, but I hadn't thought about that until you brought that up. So thank you for that. First, regarding the police, we have had conversations with the police department in Brooklyn, and particularly the 67th the 67th precinct. 67th precinct is one of the precincts that is in the central Brooklyn area that we often have many patients coming to, being taken care of and that are being followed and monitored by the NYPD. The local clergy, who are also looking at doing work with violence prevention and violence intervention, in addition to the police department, created something called the 67th Clergy Council, which is a way to bridge both the religious community and the NYPD in that particular district to foster community development and community relations. In New York, we have police officers that we refer to as, they're from community affairs, and instead of wearing the dark blue police uniforms, they have like these sky blue polo shirts. And these are regular police officers and detectives, but they're trained a lot more in community mediation. So if there's like a major parade or major event, these are people who they'd rather have around because they're a little bit better skilled at in dealing with management of people, particularly folks who might be a little bit inebriated or who might be angry because of a certain situation that's taken place within the community. And so we've been having dialogue and doing some trainings with the 67th Clergy Council to start with. The next phase of what we'd like to do, and we've applied for some grants with NYPD about trauma-informed care. We didn't get one, but we're going to be applying for some more because I think there's a level of education that needs to happen a level of understanding that needs to happen with both members, from the community and the precincts. But understanding, like, what does a community dynamic look like? I've had major run-ins with NYPD in the emergency department as a physician, being threatened, and I'm the physician who's taking care of the patient. I wish this only happened once, but this has happened multiple times. Matter of fact, this has happened probably like around Thanksgiving. Matter of fact, Thanksgiving was the last one where I had a major run-in, but I also had the same run-in with the folks from the same precinct 2 weeks before. And so there's a lot of education that needs to take place. And I had to do a whole lecture and talk on trauma-informed care and community violence, which they weren't anticipating in the middle of a hallway of a busy emergency department. But I think it was effective nonetheless. But that's just one of the conversations that needs to take place. One dynamic that we kind of often overlook are school safety officers. School safety officers are a major interface with kids coming into the building. And in New York City public schools, all kids are going through metal detectors when they come in the building. So you're dealing with trauma at home, you're being interrogated by school safety officers, and you have a bad day, and they say, oh, you can't bring that glass bottle in, and now you got a major run-in with the school safety officer who's threatened you. Then all of a sudden you exchange words, and because you cursed out the school safety officer, now you have a suspension on your record, and you can't come back to the building unless that principal decides to do an in-school suspension. But now you have a suspension on your record. You've become labeled, and it's just one other thing red flag that you have against you before you've even entered the system. And so doing a lot of education-based programming is something we're trying to work on with the school safety officers, particularly on the campus in which we work, and then start moving into other campuses. There's a young woman in the back. Yes.
Is there a coffee branch here in Buffalo? Any thoughts to do that, and if so, could you give out the contact information?
We don't have a Covey branch here in Buffalo. In Western New York, there are some, I forgot the group in Rochester, and I think there's something here in Buffalo. There's an organization nationally called NNHVIP, which is the National Network for Hospital-Based Violence Intervention Programs, NNHVIP. And that's a consortium of intervention programs from around the United States. Covey itself is a member. And one of the things that I mentioned a little bit earlier is figuring out who's already doing community-based interventions. It might be a group of fathers. It might be a group of mothers that are just focusing on stopping crime. It might be a group of concerned citizens that want to do after-school programming. It could be medical students who are already working in the community doing readings down in the Fruit Belt. I remember Dr. Prasad mentioned that before. And that's kind of maybe a liaison and kind of start from there. It doesn't have to look like what we do, but one of the things that we are looking to do is do more training for other groups, because that's a way of creating a different level of sustainability. If we can keep money in the local communities and not necessarily trying to outsource people from outside of Western New York to do this kind of work, I think it'd be a lot more effective. Plus, people here have a very different, intimate view of what the community needs are. But we are open to do trainings for some other groups that are interested that are up here. But we don't have Covey in Buffalo yet.
So I wanted to thank everybody. This conversation obviously needs to continue, and we're going to have an opportunity to continue to have the conversation after, if people choose to continue to speak with Dr. Gore over lunch. The Department of Emergency Medicine is hosting a lovely lunch right outside this room, and people are invited, and the questions can continue. I wanted to thank you so much for really continuing this feeling of being inspired and giving us something to aspire to, as well as being inspired. Thank you to your family for raising such a cool guy who is now apparently passing it forward. So that's really wonderful. I also want to thank all of the alumni for coming, and in particular, just in mentioning a few thank yous. Thank you to everyone who participated in planning this weekend. Jen Britton and her team from alumni, always amazing. Jafar Angevin, who helped organize the post-baccalaureate students. David Milling and Margarita Dubakovich from Diversity and Inclusion, who really helped pull all of this together and are supportive of this. Susan Orange, who worked in graduate medical education, and of course, our SNMA chapter members, who have been absolutely amazing in spreading the word for this program, as well as our Second Look program, which is coming up soon for students, underrepresented students who are coming back to UB. So with that, thank you, and let's continue these ideas and conversations.